5 minutes. That's what we're diagnosing as status epilepticus now. So at that point, we're going to want to be always thinking about airway, having someone anaesthetic trained there, being able to carry out RSI as required at sort of earliest opportunity that's needed. Yep. Any questions?
When you said impending procedures, what do you mean by impending?
So that's just one of the terms that's been sort of used now, instead of, because there's some evidence saying that with status epilepticus is 30 minutes, but now what you're saying is going on beyond 5 minutes. Some papers are using it as pending status epilepticus. So it's, but yeah, it's just different terms. Any more questions for anyone? Sikina, did you want to go with yours out?
Yes, that's fine. I'll just share my screen.
Okay. Thank you so much, Ian. That was very useful. Very nicely presented, TBI. And definitely we have to cover the secondary injury to the brain. Basically, what we are doing in ITU is preventing those secondary injuries, which is mostly the biochemical aspect of the TBI. So our next presenter is Sikina, and she'll be discussing the drugs which are used in the management of status. Okay, over to you, Sikina.
Thank you. Yeah, so I'll be going through the drugs used in status epilepticus. It's quite a long presentation, so I'll just go through the main bits. These are just some of the objectives. I will send this out afterwards, but things that we won't cover today is pediatric patients, pregnant patients, and then the management of epilepsy in level 0 to 1 patients. So just focusing on our normal 2 to 3 patients. So Ian's already gone through this, but I guess I'll just reinforce it. So status epilepticus is defined as a continuous seizure activity which is greater than 5 minutes, or it can be more than one seizure without recovery in between them of more than 5 minutes. Refractory status epilepticus would then be defined as a continuous seizure despite treatment with 2 anticonvulsants in their appropriate doses for the patient, and that can occur in both convulsive and non-convulsive states. So just literally moving straight onto the drugs part. So the current agents that NICE have approved for status epilepticus, so in early status, so between 0 and 10 minutes, the most important things that we do is secure the airway, give the patient high concentration oxygen, make sure we can assess their cardiac and respiratory function, check their blood glucose, and secure IV access. So within the first 30 minutes, our first choice is IV lorazepam, purely because it has got IV, like this drug does have IV access, and we can repeat that after 10 minutes if the patient is still seizing. The other choices is also buccal midazolam at 0.5 milligrams per kg. That's outside of the hospital. So if a patient has, for example, a seizure at home, or rectal diazepam at a dose of 10 to 20 milligrams. So as I mentioned, you can repeat IV lorazepam 4 milligrams after 10 to 20 minutes. It's generally shown to have better seizure termination compared to phenytoin or even phenobarbital. We also can administer glucose if the patient is hypoglycemic. Habenex if we think that the patient may have been abusing alcohol and they have impaired nutrition, and also treat acidosis if we can manage to take their ABG. We do give their normal anti-epileptic medication if they are known to have seizures prior, and also take levels of the whichever drug that they're taking from before. So After the patient has had established status at so between 0 to 60 minutes, we should try to establish why the patient's having a seizure. We can give phenytoin IV. So the max dose in the BNF is 20 milligrams per kg, but locally our max dose is 18 mg per kg. We can also give phosphenotoin or phenobarbital. They're not commonly used, but it's an option. SIGN guidelines also recommend sodium valproate at 20 to 30 mg per kg IV. And then American guidelines suggest levetiracetam. I know there's quite a few questions that we usually get about the max dose. The max dose is actually 4.5 grams as a loading dose. Obviously, that's dependent on the patient's weight. And then if a patient is suffering from refractory status, so between 30 to 60 minutes, we transfer to ITU, do EEG monitoring, intracranial pressure monitoring, and we can use propofol, obviously, if we intubate them. So propofol will do kind of two things in one, so sedate and also control their seizures. Midazolam also works as a continuous infusion. And then again, we don't see this much, but thiopental also does the same thing. And then we continue this anesthetic of choice, whichever we decide, for 12 to 24 hours after the last seizure. So I'm not going to go through the evidence because there's loads of different trials and it's hard to remember. So just moving on. So as I mentioned before, the algorithm for treatment locally is that we give lorazepam. If that doesn't work, we can follow it with either phenytoin, sodium valproate, or levetiracetam. And again, if they're intubated, then propofol, midazolam, thiopental, or phenobarbital. So generally, we avoid phenobarbital and thiopental because of their they do have a high risk of respiratory depression, hypotension, and they have quite a long half-life. If we give IV phenytoin too quickly, that can also cause hypotension and arrhythmias. And phenytoin also contains propylene glycol. And generally, we should caution that use if we're assuming a toxicity. So just a little bit of pharmacology. So some of these which affect the sodium channels are phenytoin, carbamazepine, valproate, and topiramate. So also affecting the calcium channels are valproate and topiramate. So they have dual action, and also lamotrigine. Obviously, we don't use gabapentin and pregabalin much, but they are also a subunit of calcium channel blockers. Levetiracetam binds to 5V2A protein on the walls of the vesicles containing glutamate. And then we also have drugs that affect the GABA system, so benzodiazepines and phenobarbital. So lorazepam, the mechanism of action, like I mentioned, so it binds to the postsynaptic GABA-A neurons at several CNS sites. That enhances the inhibitory effect and then causes a less excitable state because there's a shift in chloride ions. So generally we do give 4 milligrams IV and we can repeat after 5 to 10 minutes. There's no dose adjustment for renal. It's a very quick onset of action between 1 to 3 minutes. And the duration of the effect is also long, so 4 to 12 hours, which is great. Metabolism, it's hepatically metabolized. It's got a longish half-life of 14 hours and we store it in the fridge. It's our first line purely because it's got a low risk of respiratory arrest and hypotension compared to diazepam and some of the other medications too. So midazolam, exactly the same mechanism of action. We can give it at 10 milligrams or 0.5 mg per kg IV or buccal. It can accumulate in renal impairment, so the half-life is prolonged. And it generally then leads to prolonged sedation. So for example, if the patient did have previous renal impairment, we wouldn't really go for this option. The onset of action, again, very quick, of less than 5 minutes, but it has a lower duration of action, which is why it's better if we are going to give it as an infusion. Again, it's hepatically metabolized and half-life is about 3 hours. And It's prolonged if the patient has cirrhosis or heart failure, if they're obese, and again, if they've got renal impairment. So diazepam, again, same mechanism of action, similar dose of 10 milligrams. We don't actually ever give it IM, because absorption is way too slow if a patient is having a seizure. Generally, we give it rectally, again, quick onset of action and metabolized hepatically. So they're all benzodiazepines and have similar like metabolisms, onset of action. It's got a very long half-life of 33 to 45 hours. But there's no real difference in the efficacy of why we would pick this drug over, for example, midazolam. You can basically just give it if we don't have midazolam or lorazepam on the ward. So in terms of which drug to give, so if a patient is on phenytoin and they've got a therapeutic level, so this is if it's part of their drug history, we can add on sodium valproate at a dose of 30 mg per kg or levetiracetam. And if the patient is on phenytoin from before and we've taken the level and it's low, we just reload the patient on the phenytoin and adjust what their current dose is to try and maximize it within the therapeutic range. So phosphenotoin, I won't go into this again too much because it's actually non-formulary at Northwick Park, so we don't actually give it much. It's got a similar loading dose as phenytoin, so 20 mg per kg as the max, and it can be given more rapidly IV or IM. It does have fewer side effects as things like hypotension, but it's super expensive, hence the non-formulary. So phenytoin, we see this quite a lot. So we load the patient at 18 mg per kg locally. So maintenance, once we've given them that loading dose, the next day we would start a maintenance dose of 100 milligrams 3 or 4 times a day, depending on the patient and just clinical judgment. Like I mentioned before, it does have a propylene glycol-diluent, so there is a risk of hypotension or arrhythmias. Just information for the nurses, we would always need a filter because it can precipitate. We do need cardiac monitoring purely because of the chance of the patient developing arrhythmias. So in terms of monitoring, which again we get quite a few questions on, so after the loading dose, we take the levels 3 hours after. And then in terms of the maintenance dose, we take the level 4 to 6 hours after. We're targeting 10 to 20 milligrams per litre. Of course, you guys can just call us and we'll be able to interpret levels for you and how to dose adjust. But in terms of steady to state, it takes about 2 weeks. So if we do dose adjust, there's no point taking the levels straight after, for example, the next day or even the day after that. Generally, we'll do it after about a week or 2. And the dose is adjusted if the patient has a low albumin purely because it binds to albumin. So sodium valproate is as effective as phenytoin. The loading dose is 30 mg per kg. It's less of a sedative, and it does have a risk of hepatotoxicity and can cause high ammonia levels. So we don't really monitor levels for this, but we can do a pre-dose level if we feel that it might not be working. And I'll go through the interactions as well. I guess one thing really important to note is we wouldn't be able to give this medication if the patient has a chance of being pregnant because it can harm the fetus. So levetiracetam, I'm sure you guys know this by now, so max dose 4.5 grams. Its clearance is decreased in renal impairment and it's also decreased in the hepatic impairment, so we do have to take that into account if we are going to start that for the patient. I won't go in again onto evidence. So phenobarbital, we don't see this too much. It's got a ridiculously long half-life of up to 100 hours. High dose will generally control any type of seizure and you might need to intubate the patient. This is generally on advice of neurology because we wouldn't start it purely because of how long the half-life is, that it can cause respiratory depression and it does have an increased mortality risk. So moving on to refractory status epilepticus. So like I mentioned, it's defined as an ongoing convulsive or non-convulsive seizure, even after the patient has been administered at minimum of 2 anti-epileptics. This kind of just is a given that we would have to intubate the patient and then monitor them with an EEG. And this is where our midazolam propofol would come in. So in terms of receptor changes, so benzodiazepines, like I mentioned, affect the GABA receptors. So their NMDA expression would lead to an excitatory state, and that just makes the seizure worse. Again, I won't go through the evidence. So if we decide to give the patient midazolam, we would bolus them at 0.2 mg per kg and then start them on a continuous infusion. It have to be an infusion because it's quite a short half-life. Generally, we would notice that the seizures should stop. And if it's unsuccessful within about an hour, that's when we would have to add propofol or any other agent. So if we do decide to add propofol, just bear in mind, obviously, we kind of have low blood pressure and increased risk of respiratory depression. There's a similar efficacy between both of the drugs. So we all know how to give propofol, but it can lead to rhabdomyolysis, metabolic acidosis, cardiac failure, renal failure, and then we would just have to monitor like things like their CK, their lactic acids, triglycerides, just to prevent any sort of propofol-infused syndrome, and then make sure that their levels are adequate before we start withdrawing if they are on, obviously, an IV medication as well. I won't go through phenobarbital or thiopentol purely because we don't use it, and I know it's a lot of information. So other drugs that we can use, so again, on advice of neuro, we might have to use immunomodulatory drugs, so things like IVIG. We can also use ketamine. Again, don't use it too much, but it is a choice. So that's generally if the GABA agonists have lost effectiveness and we just don't know what else to do. But there's limited evidence for things like inhalation anesthetics, ECT, or surgical interventions. So like I mentioned right at the start, we would have to kind of determine why the patient is having a seizure. So some common causes, it could be things like a traumatic brain injury or non-traumatic intracranial hemorrhage. It could be a benzodiazepine or alcohol toxicity, hypoglycemia, or it could even be an isoniazid-induced seizure if the patient is on that before because of TB. In terms of drug-drug interactions, just bleed past and we'll be able to tell you about those. So one interaction I think we should all know, I know generally on microbiologists and stuff, we love meropenem, but in terms of meropenem and any sort of, in terms of carbapenems and valproate, carbapenems do increase the clearance of valproate. So it increases the metabolism. We generally recommend not to use these two together because the patient has got a higher chance of seizing. But if this is completely unavoidable and we have to use the carbapenem, then we just have to monitor the valproate concentration. So in terms of enteral feeding, the phenytoin has reduced bioavailability if the patient is receiving an NG feed. So we hold the feed 2 hours before and after. So important to let the dietitian know. Levetiracetam, we don't have to worry about it. It's got 100% oral bioavailability. And carbamazepine, it's got a potential for benzoyl formation. So again, just let us know. We can help to adjust the feed. So I mentioned before about albumin and protein binding. So valproate and phenytoin, if they're given together, they actually compete for binding to albumin. So if you have a low albumin, there's obviously increased concentration of phenytoin-free fraction. That can obviously lead to increased levels, but phenytoin doesn't actually displace valproate. So we would have to adjust the level if the patient does have a low albumin. And in terms of ITU considerations, if the patient is delirious or is quite disorientated, it could be related to the anti-epileptic. we would generally, I guess, give drugs to try and treat that. Excessive sedation probably due, if they're on phenobarbital, it could be due to this, and it makes their neuro exam quite difficult. Bradycardia is commonly caused by phenytoin, and like I mentioned before about ammonia and valproate, it can lead to an increased accumulation of ammonia, and phenytoin and vecuronium have an interaction, and this can cause neuromuscular blocker resistance, again requiring higher doses. So just picking out a few bits from this slide, renally we would have to adjust levetiracetam, midazolam. They all metabolize hepatically, so again we have to monitor their liver function. And then last but not least, the seizures could actually be drug induced. So this could be things like antipsychotics, antidepressants, tramadol, quinolones, beta-lactams. So again, we can just look at the drugs for you and see if maybe it could be because of it could be drug induced. So summary, I know this was so much information, but so I guess main things you guys need to know. So prompt treatment of status epilepticus is always generally with lorazepam. We can give valproate, phenytoin, or with the lorazepam, yeah, and we can give valproate, phenytoin, or levetiracetam after initial therapy if that doesn't work. If the patient is intubated, we usually give midazolam and then follow it with propofol or vice versa. There's not much evidence of like which one is best. Every trust does something different. And of course, we just consider the following of adherence, their PK, the patient's renal function, hepatic function, and also their drug-drug or food interactions as well. I know this was so much information, but are there any questions? I can send the slides out to you because I know there's a lot of information on all of them.
That'd be great, thank you.
That was amazing presentation, Sikina.
It was a very busy one, yeah.
Yeah, but it was very useful actually, and practically too. I just want to ask one question that if we don't have an IV access, is buccal midazolam readily available in our trust for adults? I know it is available for the pediatric population.
Yeah, so it is available for pediatrics and we have it in pharmacy, but the only thing is that we don't have it as stock on the ward. So if we don't have IV access, we would have to give rectal diazepam.
Okay.
Yeah.
Because I'm just asking this because I was doing on-call outreach 118, and I had a call from a psychiatry department, and the patient was having this status epilepticus, and because it was an outpatient clinic, he didn't have any IV cannulation, and we were struggling to get one because he was constantly seizing.
Yeah.
And at that point of time, I was thinking if, and I had my yellow bag, but obviously we don't have any buccal midazolam in that. So I was struggling to get the fits under control. But after a lot of efforts, I did manage to get an IV cannula in, and I asked 3-4 people to just hold his hand steady so that it was quite funny. I'm just wondering, like, because in person, in practicality, it's very difficult to manage such a situation.
Yeah. So generally, A&E have obviously all three options. They have buccal midazolam, rectal diazepam, and obviously IV lorazepam. I guess the only issue, and even for example, if this was a patient at home and an ambulance was called, they again have all three options. But the only thing I would be able to suggest would be the rectal diazepam because that's readily available too. But if buccal midazolam was needed, you would just have to call on-call pharmacy and we would try and get it to you as quick as possible, or obviously getting it from somewhere like Jack's Place or something like that. But there's not actually any other option. IV access is like the best option at that time, which I know is very difficult. Yeah.
Would you give a different amount of the buccal midazolam?
Sorry?
Is it just per weight, the buccal midazolam? Would you just give it the same amount as you would to a child?
It would be weight-based. It would be weight-based, yeah. It comes in a variety of different strengths.
I think he's trying to ask, like, what is the dose of buccal midazolam for an adult in comparison? Because if we are using a pediatric concentration for an adult, then I think, is this the question?
Yeah. 10 milligrams, is it?
We have to give 10 milligrams.
Yeah, it's 10 milligrams, and then you can repeat that after 5 to 10 minutes if the patient, obviously the seizure hasn't subsided. So it's 10 milligrams.
Okay. Good. Wonderful. Any other questions? Okay, I guess no.
No, who shall I send this presentation to?
You can send it to Dr. Amya.
Okay, perfect.
I think his mail is now working. I was just having a word with him, so you can send it to him.
Perfect. Okay, great. Thank you so much for listening.
Thank you so much, everyone, for attending this session, and see you in the next one. Bye-bye.